I'm told we're ready to start, and that I'd better get my act together. So it's a real pleasure to introduce Susan Murphy to you. I first met her, she doesn't remember this occasion, so I guess we made a big impression. I first met her at one of the Pathways to the Future workshop that we used to run years and years and years ago for junior faculty. But anyway, she's here today, and I'm glad that she is. I enjoyed the first talk. But the question I asked myself was, how do I connect Susan Murphy with Ralph Bradley? And I'm not going to go into her professional life because you've heard all about that. But anyway, Susan grew up in a family of women in Louisiana, a family of genteel southern ladies, y'all. Think steel magnolias. And grits. She had to have grits for breakfast. I had breakfast. Anyhow, in contrast, Ralph grew up in Canada, which is as far away from Louisiana as you can get. I'm sorry if I don't say Louisiana properly, but anyway. But it's about as far away as you can get. But as a Canadian, Ralph, of course, was an avid, a fanatical hockey player. This is ice hockey, okay? And, but by the time I knew Ralph, I wasn't, this is in Florida, in the mid-70s, early 70s, he wasn't playing ice hockey, but he'd become an addicted bridge player. So how do I bridge Ralph with Susan? Well, Susan, this genteel southern lady, moved north and discovered hockey, ice hockey. And she is now an avid, a fanatical, an obsessed, an addicted hockey player. In fact, she's so obsessed about it, her family limits her discussions on it to an hour a day, after which she has to ice it. And we'll let you talk about ice hockey if you like, but this is an after-dinner talk. We can be a little more, I don't know what the word is, but anyway, Susan, your turn.
Okay, so I was thinking, there's just pictures, there's no math or anything in this talk, because I wasn't sure exactly who would be in the audience. Okay, so this is from the work that I did for the last, say, 15 years or so. I don't work in this area. People in our group still work in this area, but I have left it. But I think you're going to see the connection to mobile health. You'll see why I ended up in mobile health. Okay, so this is these are adaptive interventions. The idea is with this notion of adaptive interventions is that they're composed of sequences of treatments, and the treatments are tailored to the individual. And the way they're tailored to the individual is based on how the individual is doing in like if they're responding or they're not responding or they're taking their meds. And there's a lot of interest in the medical and the behavioral science communities in adaptive interventions. And the reason why is because they operationalize clinical practice. So if you think about a clinician and he has a patient who, say, has high blood pressure or some other more chronic illness, that clinician knows they're going to have to help that person over a longer period of time. That clinician knows they're going to have to make a sequence of decisions. This particularly happens, for example, with diabetes. People tend to go from one drug to the next as the disorder progresses. So there's many different kinds of disorders where you have to think about sequencing of treatments. And the clinical community has been very, very unhappy with the way in which we do medical science today, because we just do these two-arm randomized trials of pill A versus standard care. And they know that has nothing to do with what they do in real life. Because in real life, they have to think about sequences of different kinds of medications, because most people may not respond or may stop responding. So that's the interest in this area. And there's a whole bunch of now of these interventions that have been implemented. I list 4 examples here. McKay actually has a whole book on adaptive treatment for substance use. I'm going to show you some of Marlowe's work in the next slide. And, it's really interesting. I was a consultant on this project. Oh, I got to tell you first why. Okay, yeah. So when people hear about these adaptive interventions, they got really hot, and so people just wanted to do them. You know how it is. You got to hammer everything. You know what I'm talking about. And so I always wanted to have this slide that said, look, let's think. Are we really in a setting where we want to use our hammer? Because we shouldn't be using it if we don't want. And the characteristics of an adaptive intervention, or the need for adaptive intervention, has to do with the need to make a sequence of clinical decisions. So there's two classical settings in which we see this happen. The first is you have an illness, and it's known that most medications or most therapies only will help maybe 60%. So a person that shows up in your office, you know there's a good chance they're going to show up again because the first intervention is not going to work for them. So you have to be prepared to make a sequence of decisions regarding treatment. So what works for one person may not work for another. The other setting in which you really see adaptive interventions is management of chronic disorders, or disorders that wax and wane. And you want to be able to have a more intensive intervention when it's needed, then reduce back to like a maintenance therapy or a monitoring therapy when the person was doing better, and then go back up again. And for example, in major depression, one of the problems, we have some pretty good medications, but it's known that they'll work for a while, and then they just stop working. And so you have to think, what am I going to treat next? And in these chronic, the last point, this is associated with chronic disorders, is even if all you have to do is take one pill a day, say a hypertensive blood pressure pill, adherence, most people can't. It's just, that's too burdensome when you're talking about 50 years. So how do you manage that, keeping people on task? These are the settings in which one would think about adaptive interventions. Okay, so now I get to talk to you about this one. This is the intervention that I was a consultant on, and I have talked about this intervention to many different audiences because it's one of my very favorite. And it's in drug abuse, and it's a combination of a social treatment and a medical treatment. And it points to the fact that many areas of our society involve sequences of decisions. In particular, in the social sciences, in criminal justice, in welfare management, they involve sequences of decisions, but we're not running experiments to figure out how to do that. Yet here's an area in which it's a combination of a social problem, criminality, and a drug abuse problem, a medical problem, and they're running experiments. So this itself is just the intervention, but what happens is people come into this drug court program, the way you get into a drug court program is you've committed an offense, it's drug related, and you're offered the chance to go into the drug court program, and if you graduate, you won't have to go to jail. So they come in, and they're divided into low and high risk. High risk has a diagnosis of antisocial personality disorder or formal drug abuse treatment. These people are considered, they need more help. And then there's the low risk people coming into the program. And they both get the same standard drug abuse counseling, same standard, it's a group-based counseling. But the difference is the people at high risk get a very expensive social intervention. Bi-weekly court hearings with the judge, extremely expensive. Whereas the people at low risk get as-needed court hearings. And then every month they monitor these people, each offender. And they observe if they're doing fine, they're following the rules of the drug court program, they just stay where they are for the duration of the program until they graduate. But if they could, instead of doing well, they could be non-compliant or non-responsive. And non-compliant in this particular setting means they miss 2 or more drug abuse counseling sessions because they're mandated to go to counseling, or they're not giving their drug urines. Every week they have to do a drug urine screen, and they're not showing up for 2 or more drug urine screens. So then they're non-compliant. And what do? That's the dashed line. They step up the court hearing, the very expensive intervention. So that's the second group of people, second type of result of every month's evaluation. The third type of thing that can happen at every month is they could be considered non-responsive. And in that case, this is someone who's compliant, they're following all the rules of the drug program, but the drug urine screens they're having 2 or more positive drug urine screens. So it's thought that that's a person who's really trying hard, but the medical illness is problematic, and they need more medical care as opposed to judicial supervision. And so they're stepped up to what's called intensive case management. And that has individual counseling, and it also works on their family situation, their social situation, tries to provide more social support for them so they can stick with the program and graduate from the drug program. So this is called an adaptive intervention. You might, if you were in many areas of medicine, they're called treatment algorithms. They go by a whole variety of names depending on the medical field. But they're decision rules, right? These are just decision rules. They input information on you, and they output what treatment to provide you repeatedly over time. So some of the decisions, some of the critical decisions that when you're trying to design one of these adaptive interventions fall into these 3 categories. What's the best sequencing of treatment? What treatment should I provide first? If they don't do well, what should I provide second? Or if they do well, what should I provide? Because these are chronic disorders. You don't just drop the person off. You have to stay there with them. How soon do you give up on the first treatment because it's not performing well? And so how soon then do you change? Or if they are doing well on a treatment, how soon can you transition into, say, a maintenance therapy or something like that? And then what information do you use to make those decisions? How do you individualize the choice of the treatment, the timing, and changes the treatment to the person? These are the big decisions that come up in this area. Clinicians have to deal with these decisions routinely. Yet we, as a society, do not run trials that help them address these decisions, these types of decisions. Yet we know randomized trials give us high-quality information, particularly if we want to develop an intervention. So what we worked on is these trials called sequential multiple assignment randomized trials. I didn't make up this, actually. I'm a typical statistician. The name I made up was SPAR. And one of the scientists that was involved said, Susan, why don't you just put a T? It sounds so much better. And I did, and actually, that really helped sell this. I cannot tell you, that little, just putting that T on the end helped a lot. Because, you want to be smart, right? So these are, what they are is a multi-stage clinical trials, but not the multiple stages in the sense of, here it's each person goes through stages of treatment. So every participant progresses through stages of treatment. Each stage concerns some critical decision, one of those types of critical decisions from the last slide. And you have a randomization in each stage. So each person gets randomized potentially multiple times. And the purpose of this is to inform the construction of an adaptive intervention. Again, there's a notion of full factorial here, which is quite different from the way we think of full factorials. I'll show you a full factorial shortly. Actually, maybe on the next one. Yes, this is a full factorial. So I'm going to talk to you about this. This is a study that just was finished a couple of months ago. This is at Hopkins, and it's by Andre Jones. This is for women who are pregnant and they're drug addicted, and the whole goal is to keep them off drugs long enough so they can give birth to a healthy child. That is the primary purpose of this study. The problem is, even that is a chronic relapsing condition because it's very hard for these women to stay off drugs. And they had developed this treatment. It's not medication-based, of course, because these are pregnant women. It's called reinforcement-based therapy. It has 21 or 20 different components, very complex intervention, and the women have to go, I think, 3 or 4 times a week and spend most of the day in the clinic. It's very expensive, and they had run it, and they had tested it in trials, 2-arm trials, and it was, it had good response rates. I think around 60% of the women made it through and gave birth without being predicted by the end of the study. So this is fantastic in that world. It's really good. It doesn't sound good, but 60% is really good. The problem is 40% of the women did not do well, right? And not only that, it wasn't only that 40% of the women didn't do well, it was that some of those women actually didn't really seem to need the treatment. They just started doing well right away. They got with the program, they were together. So the whole purpose of this was, can we reduce the cost, the intensity, the dose, the scope of the intervention safely and still have an efficacious intervention? But you knew that this is a chronic disorder, so you might have to step it back up. So the first randomization, the women come in, they're usually like a month pregnant or so. They're randomized to the standard care versus a reduced version. Then within 2 weeks, very tight trigger because of the problems with the infant, the unborn infant, and the worry about harm to the unborn infant. The response here is measured in terms of compliance with showing up at the site. If they're a responder, there's two options, two tactical options. You either reduce the intensity and scope, or you stay the course, stay on the same thing. If they're a non-responder, they're not being very adherent. Two tactical options, you increase the intensity scope, or you stay the course. Because it could be if you stay the course, they'll recover, they just need more time. This is a full factorial in this set, a balanced full factorial in this set. I'm telling you, someone in experimental design has got to work in this area, because, I'm just making all this up. But anyway, we won't discuss that. We'll just go on. But this is a balanced full factorial. Okay, and I just wanted to show you what happens with these trials is within them are very simple embedded adaptive interventions. Now, one is going to use the data to form more complex adaptive interventions at the end of the study, but within them, there's very simple ones. And this one in red is one such simple adaptive intervention. Everyone starts off on standard RBT. If they respond, they stay on it. If they don't respond, you increase the intensity of the scope of the intervention. Very simple. There's 8 such little interventions in here. This actually looks very complicated, and when I first started talking about this sort of thing to many people, they were very concerned about sample size, as you can well imagine. But this is a factorial design. The factorial designs have enormous, they're very efficient designs. They actually use the data well. Okay, I want to, because there were so many obstacles initially to even thinking about this, actually I have to be honest too. I was thinking about these types of studies. At the same time I was thinking about NIMH funded 2 large trials, one in schizophrenia and one in depression. And if you looked at the application from the investigators, it was all about sequences and treatments. Then you go to the stats section, and they ignored everything. And they just compared the first treatment versus a standard. It was a complete disconnect between the statistical world and the scientific world. And NIMH ran these massive studies. One's called STAR-D. You can Google it, STAR-D, Arcade. And they were after sequences of treatments, but they weren't all that well designed because we were not there. We weren't there. So as a result, there was a lot of interest in this trial design. At the same time, there was a lot of concern. And because this is me trying to address this concern. So the primary reason why people were concerned about these trials, they seemed very complicated. And they thought, well, look, I have tested the first 2 treatments already. In the trial I showed you, it was what treatment to provide first, what treatment to provide second. Those were the 2 big decisions. They thought, I've already tested the first treatment. I know what it is. I did a randomized trial for the first treatment, so I'll just take that one, and then that best treatment, and then I'll run a non-responder study and a responder study, and I'll get the best treatments in those. And I'm done, right? That saves a lot of money because you don't have to run that first study. So I'm going to talk to you about why that's not such a good idea. And I'm going to go from I'm going to increase the level of convincingness as I go through this list. Okay? So this one is maybe it's convincing to me, but it's the least convincing of all. And it's that when you think about sequence of treatments, say like A followed by B, A may set the person up for success in B. And this happens a lot in behavioral treatments, particularly very low intensity. For example, low intensity telephone counseling. People tend to do better if it's preceded by face-to-face counseling. So the face-to-face counseling sets them up for success in the telephone counseling. So it's a positive synergy within the sequence. This one, actually, the clinicians are acutely aware of this, and they're very concerned about it. And this is negative synergies, and I'll give you some real-life examples of this. And the problem is you may have a treatment that appears very efficacious as a first-line treatment. It gets a lot of responders, but it carries with it side effects that if you get those side effects, all of a sudden a host of treatments are no longer possible. So this happens in treatment of psychosis. There's these antipsychotics that are extremely efficacious, but they carry with them certain movement disorders. And once you get these movement disorders, you never get rid of them. They're with you forever, and a whole host of treatments are no longer possible for you. So it's known that you don't want to start off with these very efficacious. You want to use them for last resort. They're last resort treatments because of this side effect. The other thing that came up in, there's a guy, M.D. Anderson, some of you may know him, Peter Thal. He's a Bayesian. In cancer, when you're looking at chemotherapies, they often do sequences of chemotherapies. And the big concern there is we know that the most effective chemotherapies are also the most toxic chemotherapies. That goes together hand in hand. So the question is, if you're going to if you have time to run 3 different chemotherapies in a row, for example, should you start off with the most effective chemotherapy? Not necessarily, because if you start off with the most effective and that you make that person so frail that they cannot respond to a subsequent chemotherapy, then the overall success rate for that trial, the trial of 3 therapies, will not be effective. So you actually want to start off with a less immediately effective chemotherapy just so someone can be available for the subsequent. And then this is the last one I'll talk about today. And this one I find particularly convincing. I'll be able to tell you a story about it. And it has to do with these sample selection effects. And I did not think of this. A clinician told me I should think like this. And it has to do with the kinds of people who will enroll in, remain in, and who are adherent in a trial of standalone treatments versus a trial, a sequential multiple assignment randomized trial. And so what do I mean? Suppose you're struggling with alcoholism, and they say, well, look, I'd like you to enroll in a trial for 6 months. You're going to be randomized to placebo or naltrexone, a pill. They both look alike. And you're supposed to stay on it for 6 months. You know, you could be, after 2 or 3 weeks, you may not be doing well at all, but you're stuck. You have to violate the rules of the study and get off that pill if you're not, you don't have any alternatives within the context of the trial. Whereas in one of these sequential multiple assignment randomized trials, if you're not doing well, you know something's going to be done. They may change your treatment, or it may be stepped down. Okay, so I want to give you a story here that's related to this one. So one of the guys, he's at UPenn. This is in substance abuse. He had been running these non-responder studies, and he had his big intervention that he thought was the best thing, in the world for people who were not responding to their initial treatment. And I convinced him to run one of these trials where he started off with people, and then only, he had first-line treatments, and then they got re-randomized to second-line treatments. And at that time, I was still going to a lot of psychiatry meetings every year. He saw me at one of the psychiatry meetings, and he wasn't very happy with me. He said, "Look, that trial has been a disaster. You've messed up everything." And I said, "Well, what happened?" And he said, "Well, I bring everybody into my study pieces of alcoholism, or either that or cocaine, because he ran 2 at the same time. And he says, he told me, I brought them all in, and then some subset did not respond. And most of the people who didn't respond refused to have another treatment. They didn't want treatment anymore. They didn't even want to be in treatment. And he says, this is a disaster. My whole trial is ruined because I had to re-randomize these people, and they're not even there. They're gone. They dropped out of the study. You ruined my trial. And I went back to him and I said, well, who do you think was enrolling in your non-responder studies? He was getting very special non-responders in his non-responder studies. He wasn't getting the ordinary run-of-the-mill non-responder. He was getting these special non-responders. And how do we know those special non-responders? They probably have more social support, they're more highly motivated. They're going to do better, differently, than the people, the normal non-responders. And so now what he's done is he's working on how do you re-engage people back into treatment. So you're not doing well. What transitional treatment do I provide to you to re-engage you? But he would have never done that if he hadn't run a study like this. His non-responder studies looked great. And so that's another reason why you might want to run a study like this. So the summary is you want to be able to control for, if you're evaluating initial treatments, you want to have some way to control what comes next. If you're evaluating secondary treatments, you might want to control what comes first in the analysis. I just wanted to show you another study. This study is over, the paper is out. This is a pilot study in Minnesota. This is in adolescent depression, and this is a little different. It is also a balanced factorial design. So the kids came, these were adolescents, they came in, they got randomized. This is called interpersonal therapy. The A means adolescent. The interpersonal therapy is it's thought that one of the reasons why they're depressed is because they don't know how to have good interpersonal relationships, and they need to be helped to learn how to manage that. So the 2 big decisions in this study was how long do I keep the person in the first stage of treatment? The first stage of treatment was always going to be IPTA, no matter what. But how soon do I give up on that treatment? And then the second question was, if they're not responding, what do I do about it? Do I now add a medication? It turned, in adolescence, there's a lot of resistance by the parents to providing medications to kids who are depressed. So medication is the second line type thing here. Anyway, they were randomized to a late decision point versus early, and then re-randomized if they did not respond. The definition of non-response, you see it's written here, this is called the Hamilton scale. It's a measure of depression. I just wanted to go through some of the thoughts you might go through if you were a clinical scientist or you were working with a clinical scientist who wants to design one of these studies. And the first thing, of course, is decide what you want to investigate. Do you want to decide what the first line treatments are and the second line treatments? Or do you want to decide how long you should try a treatment before you give up, and then what should the next treatment be? Those are different kinds of, you want us to decide what one wants to do. And the second thing, to me this is a big issue, particularly when I first was working in this area, I had this whole theme, and I still kind of have it, is there's nothing that upsets me more than the clinical scientist going to a biostatistician and saying, my patients did not adhere, please do multiple imputation and save my study. Because non-adherence is an outcome of the medication. And so I always had this idea that I would restrict the non-responders into the non-adhering non-responders and the adhering non-responders. And maybe I should give them different treatments. But the point that I'm making in all this text is don't do this unless you have really solid evidence that they should be getting very different treatments. Instead, collect whether or not they're an adherer, and then analyze the data to discover you should treat adherers differently from non-adherers. So keep things simple. So I'm going to show you some of the primary kind of hypotheses. Actually, I'll only show you, there's like 4 that are currently in use that I know of. And I'll show you 2 of the 4 that particularly sample the type of primary hypotheses, and that's how you determine your sample size, as you well know. And then, of course, there'll be secondary analyses that we can use this trial will be powered for the secondary analysis. This is pretty classical. If you look at NIH grant, it's proposing a clinical trial. So here's 2 primary analyses one could consider. As I said, I've seen 4 different types used. I'm just showing you 2 of the 4. The first is you're in a setting where the sample size is highly constrained. What you do, you might say, is I'm going to look at the main effect of the first treatment. Remember, this is factorial design. Main effect of the first treatment, that is controlling the secondary treatments, i.e. the design of the trial controls the secondary treatments. I want to compare all the sequences starting with A versus all the sequences starting with B. Those are 2 treatments I randomized to. That would be a highly constrained setting. And here's a schematic of, y'all all know this, but I'm going to show you, I'll show it to you anyway. A schematic of this is you compare everyone following a red path. This is starting with A or B, and then there's different alternatives afterwards. Everybody following the red path versus everybody following the blue path. A main effect. This is a main effect half your study. And then another one, this one has been used quite a few times because many of the investigators that have used these trials are used to do non-responder studies. And so they're coming to the trial and they know that they have to get a lot of non-responders. So here the focus is among non-responders, what is compare the 2 alternatives. The alternatives on this tier are switch to C versus augment with D. That's the way I'm phrasing it. So among non-responders, you just focus on your non-responders and you size the study to ensure that you can make that 2-mark comparison. And if I think about that pictorially, I look at everyone who's in the red group versus everyone who's in the blue group here. Again, it's a main effect, but it's a main effect nested among non-responders, right? That's when you have these sequential randomizations, the main effects become nested. An example, there's a lot of really interesting statistical methods that are, one could say are really interesting to you and me, because they have a lot of issues technically. But then there's simple statistical methods that scientists can do that don't require sophisticated statistics or anything, and this is one such one. It's a secondary hypothesis, and it says, oh, look, among non-adhering non-responders, they'll do better, exhibit lower symptoms if their treatment is augmented. However, let me think. Oh, as compared to a switch. So if they are augmented, they'll do better, the non-adhering non-responders, than if they're switched. So I'm thinking here that so motivational interviewing is a type of intervention that improves adherence to treatments. So if we augment their treatment with motivational interviewing, something to get you more adherent, you'll do better than if you just switch and you give up on the present treatment. That could be a particular one, but it has a pre-treatment variable, not really pre-treatment. This is misspelled, but if it was spelled correctly, it would be non-adhering. Oh, okay. Anyway, this is an outcome of the first stage of treatment, so it's not pre-treatment in the traditional sense, but it's pre-treatment for the non-responders. So it's like a pre-treatment adjustment for a non-responder analysis. And again, you would have the red versus the blue, but you'd have a covariate in your analysis of covariance or the regression model or whatever model you would like to use depending on your outcome. And the covariate would be adherence, whether they're adherent. You would probably also have a covariate for the initial treatment as well. Okay, I want to show you another study. This study is really exciting, and it just went into the field about 6 months ago. One of the people in our group is involved in this, and it just blows my mind, this study. So there's this whole area of interventions. It's not about intervening with people, you and me. It's about intervening with clinics, with doctors. So the doctors are the units. They're the target. Now the real target is you and me, but you've got to intervene on the doctors to get the doctors to do good practice, good medicine, so that we get better. So these are called implementation interventions. If they use that word implementation intervention, that means that the treatment is on the doctors to get the doctors to treat you better. Okay? And this is really, it's sad, but we have to be realistic here. In clinical trials or whatever kind of trials we run, experimental, we develop really good interventions for you and me. And then we try and roll them out into real life. And no one takes them up. They're not even used. Unless someone is going to make money off of them, they don't get used. And part of the reason they don't get used is because the clinics are so constrained. You know, they're so busy. So how do you intervene with the clinic to get the clinic to do good practice? So the treatments here, there's two types of treatments. One called an external facilitator. This is someone off-site who acts as a backup for you. You can ask him questions about how to do best medicine, best practice medicine. Or an internal facilitator. This is very expensive. This is where we hire someone and they sit in your clinic and they try and help you practice good medicine. Okay. Right. So it turns out when you try and do these things, what happens? The clinics don't respond. And you have to re-randomize. And so some clinics have a more chronic, difficult problem. The setting is more difficult. And they're going to need a much more expensive intervention than other clinics. Right? And we would like to provide the least costly intervention to the clinic as possible. These are cluster randomized studies, right? Because you're talking about clinics. So the two critical decisions here was you have this it's called replicating effective programs. And when we say responders, insufficient responders, we're talking about clinics. We're not talking about humans. I mean, they are humans, but you get my drift. They're not patients. Insufficient responders to stand. So the clinic is not responding. It's not practicing this best practice medicine, even though it's getting this program which is supposed to help it. So what do we do if they don't respond? And then what do we do if they continue to not respond? These were the two critical decisions in this intervention. Okay, so it starts out, this study is going across the United States. It's mental health, and these are the PIs, Amy Kilborn. It started off with 100 outpatient clinics. They were all kind of tutored and trained in how to do best practice intervention. They figure around 75% won't do well. So they're going to get randomized to either external facilitation, which is kind of cheap, not that cheap, but cheaper, or external versus someone on site to help you. Then 6 months again, they evaluate if you're non-responding. And if you're in the low-level group and you're not responding, you get re-randomized to continue on the same program, or now you add internal facilitation. There's the number of patients is very high. This is thousands and thousands of patients. But the clinics are only, it starts off with 100. This is in the field now. There's some interest at the VA in this sort of thing as well. This is my last slide. So I just wanted to make some points. Secondary analyses actually are very interesting. The secondary analyses for these kinds of studies, they use a lot of, it's like forming treatment policies, but now it's just 2 stages treatment policies. We have software that one can use. There's a website here, I listed right here, where it lists all of these sequential multiple assignment randomized trials that we know of. Actually, there's been a bunch that we were not involved with, so it takes us a while to discover it and get it on the website. So it doesn't include all of them. What's really nice about it, what I really like, one of the big things that made this whole area attractive to me at the time was this now all of a sudden non-adherence is no longer considered a statistical problem that you and I have to solve. It's considered an outcome of the treatment. It means you need to figure out what to do for the person if they're not adhering. And I think that makes a lot more sense in real life than running to the statistician and asking to impute outcomes and so on. And if you have any questions, you can email me. This whole area, we have been wildly successful beyond our dreams. We didn't realize how successful we would be at the group that I belong to. Last year, NIH had, I think, 5 different programs that put out calls for proposals where they explicitly asked for this intervention, this trial design. So it was wild. We just did much better than we ever. But it's because the clinicians want so bad to understand how to treat people in real life. Okay, thank you.
Do you have any more questions, or are we all very smart now?
That's the way I feel.
Okay, so philosophical question. This is addressing the problem at the back end, right? Once you identify these people, you have these fantastic...
How do you do prevention, you mean?
How do you do prevention? I mean, much of this is related to the societal issues,
Yeah.
right? I mean, have there been any comparisons with other
They've done
developed
some
countries
cancer
to
as well.
see what's the risk rate for people getting into this kind of thing in a developed country versus the US? I mean, have there been any social studies as to what can we do? I mean, in India, for instance, we have great incentives once a backward class person can get out of high school. But the problem is they don't even get to the high school. They don't even get to the high school. So to me, it sort of looks like that. I mean, in other words...
You're interested more in preventing these illnesses.
Right, because certainly a huge sum of money is spent as to how to address the problem that exists.
Right.
But the question is, if we step back, is there any societal issues in here which actually prompts somebody to get into this kind of mess, for which there's an expensive treatment that's needed?
Right. Actually, I got into this area because of a prevention program. It's called Fast Track. It was for little kids, 6 years old, and it was the whole purpose of that. They were implementing an adaptive intervention, and it was these little kids were from high-risk families, and the idea was by providing them a variety of different interventions when it was needed, because it's an adaptive intervention, right? So they didn't all just get it. But it was all these different intervention components: reading, tutoring, peer pairing, having to do with socialization, training by the parents, parenting, and the whole purpose was to reduce the incidence of conduct disorder later in life, because that's related to drug use, alcoholism. And so that's how I got in this area. But and there has been interest on the prevention side in this sort of thing. What you're seeing more of a reflection of my interests. And that's the reason why you're seeing, like there's been studies in cancer like this, but I don't ever show the cancer. That's not my area. My interest is in mental health and addiction. And so those are the projects I'll tell you about, because those are the ones I'm interested in. You know? So you're really getting a skewed view. But I think as a statistician, at least my experience is as a statistician, I really have to understand. I think a lot of the people in this room have spoken about this to me today. You really need to understand some of the science to be able to make a reasonable contribution. And so I try to stay really focused on substance abuse, mental illness, because I have a much better understanding of the issues there. And I'm particularly interested in treatment, even though I came to it via prevention. You know what I mean? Prevention studies are very difficult. We think this is expensive. It's really expensive, prevention studies, because you're looking at studies that last 12 years. You start with these little kids who are 6 years old, and you go to their 18. Very, very difficult. there's so much going on in society, it's hard to control that, right? Yeah.
Yeah, I have a quick question. So you have introduced the case that, actually, so first you give some treatment to the patient, right? And then depend on whether the patient has respond or not respond, and then actually adjust your treatment again, right? But there's some for particular case, like for cancer, and some patient, and particular for the non-response patient, they cannot survive to the time that you give the second treatment. So basically they are not actually, they withdraw from the clinical trial, but they actually couldn't just, continue to finish the whole trial. And how is
Those
there
are considered failures. So like if you go to Peter Fowles' work, because he's actually working in end-stage cancer, it's exactly that setting. And the way they define success and failure incorporates that very point. So that's considered a failure. So if a treatment makes you so sick, if you don't respond and you're getting such side effects, you become so frail, that's considered a failure for that treatment. So that's incorporated in the outcome, at least in the cancer, in Peter Fowles' work it is. It has to be, because it really is a failure. In this world, it's not like that. We don't have people dying. So it's a different situation.
Any more questions? Oh, well, we've worked you hard today. Thank you. And I hope you've enjoyed it.